Give me a second here. I'm going to show one or two slides and then we're going to jump in, okay? So this is part three. If you missed part one and part two, I think you can access the video. You can get it from through me if you want to. Um, just to highlight, this is manual therapy for pain relief. And so, of course, the laying on of hands is a very important part of physical therapy, assessment and treatment. When we do mobilizations, grade one, grade two mobilizations, reduce pain because they activate mechanoreceptors in the body. So there's the physiological mechanism by which grade one and grade two mobilizations can reduce pain. Grade five manipulations can reduce pain through biomechanical means as well as neurological means. And so manual therapy is a very powerful tool worth mastering, which is why we're here. In the past sessions, we looked heavily at neck. We looked at some neck soft tissue mobilization, some muscle energy techniques, some suboccipital release. We looked at the thoracic spine. We covered thoracic spine manipulation, rib manipulation, and some mobilizations. Yeah, we looked at the CT junction. One of the things we didn't look at for the neck, which is an excellent for pain relief, is actually cervical decompression with nerve glides. And so we're going to take a look at that one today. I think we're going to come back to cervical. We're going to circle back to cervical at the end of the lecture. Um, I have I've got Aiden here again today, and you'll see him in a second. And I've got Marcella here today. Marcella is a physical therapy technician at our clinic, but she's a physical therapist that's been trained in Brazil, and she's working on hopefully getting to a point where she can practice in the United States, going through the process of getting licensed and stuff like that. It's a mission. Um, we looked at the rib METs and manipulation. Okay. Um, So I think what we're going to get into today is probably we're going to start at the feet and work our way up, actually. I think we're going to start at the feet and work our way up. So we'll look at some different things. We're going to look at the extremities. So we'll look at shoulder, some mobilization, some muscle energy techniques, some soft tissue techniques. Same for the elbow. We'll get into the lumbar spine. We'll do some manipulation, some stretches that are really helpful for pain relief, especially when symptoms are acute. We get pretty acute pain sometimes. There's a way that we can position a patient to open up the neural foramen where the nerves come out of the spine and then do a sciatic nerve glide in that position. It's an excellent technique for when a patient has numbness or tingling in their leg, pertaining to the sciatic nerve. So we'll look at that. That's a pretty good one. We use it quite a lot. We might do some SI and pubic symphysis manipulations and METs, just so you guys can see those. Definitely some hip manual therapy, hip mobs, and hip manipulation. That's all day, like all day. For back pain, for low back pain, for hip pain, knee pain, pain in the leg, hip mobs and manipulations, very important. We'll show some mobilizations for knee to improve knee extension and knee flexion. We're going to do several things in the ankle and foot, some soft tissue, some manipulations, some mobilizations. And yeah, so let's actually jump in. We're going to go ahead and jump into, I think like I said, let's start at the ankle and foot and work our way up. I'm going to unshare this PowerPoint. Let me open this up. Give me just a sec. Unsharing is always a mission for me. Aiden, are you good with Zoom? Ah, stop share. Okay. Through me, can you just see me now? You guys in the chat box, can you just see me? You guys aren't seeing the PowerPoint anymore. Ah, thank you. Okay, Lavanya for the thumbs up. Awesome. All right, and show up. Thank you. All right. How much battery do we have? Okay, cool. All right. So you guys can watch these. We're actually going to start off. I just got done. I was in New York, in Syracuse, New York, for a week working with a basketball team that was in a basketball tournament. It was like $1 million tournament. The winners would get $1 million. My team did not make it past the first game. They got eliminated, but that's all right. I got to work. I had the privilege of working with about 15 or 20 huge individuals. Some of them had to like duck their heads when they're walking through a door. And so while I was working with these guys, we were doing a lot of ankle and foot and soft tissue and stuff like that. So we're going to start off at the ankle and foot just because that's fresh and that'll be fun. So Marcella, you didn't know you were getting a foot massage for me today, did you? Mm-hmm. So you guys, this is Marcella. Marcella, you can say hi. Like I said, she's a PT trained in Brazil. She's here with me and Aiden this morning. Marcella, I tell you what, we're going to start off with some soft tissue for the foot. So if you want to just come lay on your stomach, and if you want to take off one of your shoes and socks, I'm going to do some soft tissue and then I'm going to let you do some. All the fun stuff. Is that cool? Yeah. All right.
I wish I got to do that first because the load is not gonna let me.
I'm just gonna do one foot. And then you can also, I mean, I know my feet suck, but unless you want a foot massage. Yeah. All right. So this patient could be a post-operative patient that is appropriate for soft tissue. They could have some swelling in their foot. They could be an ankle injury. They could be a plantar fascia patient, right? And I'll be honest with you guys, I don't do a ton of ankle, foot, calf, soft tissue work, but sometimes for 1 or 2 sessions, I might. You know what I mean? If the patient's having a lot of pain, or if you're trying to really establish like a connection with that patient so that they'll buy into your physical therapy program. So for whatever reason, I would say like every patient you have, you need to get your hands on the part of their body and the area that's painful because you never know where you're going to find tenderness or restrictions or pain. And sometimes this can be an important part of what we do. So Marcella, you can just relax. I'm going to do a really short tutorial. You guys can do gloves or no gloves. I'm going to take a little bit of massage cream. There's nothing special about this massage cream. It's just unscented massage cream. Okay. Come in close here. You guys know the techniques of, I think these are considered to be Swedish techniques. Effleurage, right? Effleurage is when you go lightly and gently and your hands do not leave the patient. Big, broad strokes. In general, we give compression when you're pushing towards the heart and you let go when you're coming away from the heart. So if there is any swelling, you're going to be pushing it up and out of that area, right? So effleurage, petrissage. No, tapotement would be like when you're hitting. I don't do a lot of that. That's more like, I don't know, massage or stuff you might see on TV. So I don't do a lot of that. And then petrissage is when you're kind of getting like really deeper in there. So you notice I'll start off and do a couple of like nice, light, gentle strokes. And then after that, maybe I'm going to go a little bit more pressure. I'm going to use my fists. And as I'm using my fists, I'm going deeper and I can start to feel if there's any knots or restrictions in the muscle, okay? So I'll do a couple of broad, deeper strokes with my fists. We'll cover the outside of the calf, the back of the calf, the inside, kind of the inner portion of the calf, and just work it out. After maybe 15 or 20 strokes like that, then I'm going to actually take my two thumbs like this, and I'm going to start over here on the outer leg, and I'm just going to press my thumbs. And as I'm pressing, I'm feeling for any soft tissue restrictions or knots. And if you do this on any calf, you'll probably find one or two spots that are restricted or have some tightness. So I'm just going like a centimeter at a time from lateral to medial. You can go from medial to lateral, it doesn't really matter, right? And this is a soft tissue technique, but it's also an assessment. Anytime your hands are on the patient, you're listening to your hands, right? What are we feeling? Is there any restrictions? You know, let's say this patient had restricted dorsiflexion, right? We want to know if, oh yeah, so my patient told me about it, but we can also feel it. So over here on the medial calf, it's nice and squishy, feels like dough, feels like a muscle should. And then in here on this kind of lateral part, kind of in the soleus, definitely got some restrictions in there. So you could give that 15 or 20 passes, you know? I mean, yeah, you can massage it, massage gun it, you can do a lot of things, but that's that's a good way to start on a calf. If we're looking at the foot, like I said, this patient, maybe they have like plantar fasciitis or they're post-operative. I'll come and sit. I'll come and sit like this. So now I've got their foot in my lap. Will you throw me a pillowcase? And then usually I'll just put a towel in my lap or something. That way I just keep my keep myself from getting any of like the massage cream on my leg or whatever. And then from here, this is actually a good position for me. I can access the foot pretty well, all right? And we can do a couple of broad strokes. You can just take the flat of your hand, kind of like a knife blade, and just dig along the foot. You can take a fist, right? Like we said, broad and shallow. Then we'll go a little bit deeper, a little bit more pressure. And then I'm going to do the same thing. I'm going to go from lateral to medial with just my thumbs. And I'm going to go pretty hard and just see what we feel. See if there's anything going on in the plantar fascia. Massage is not the cure really for plantar fasciitis, but if you have a patient, sometimes 5 minutes of that for a session or two, you know, can be worthwhile. Certainly your patients will appreciate it. It might be their favorite part of the session. So if you want to get into how to really treat plantar fasciitis effectively, you know, then you need to take like our lecture and read the research. There's a lot of connections to the back and the sciatic nerve and, you know, the kinetic chain and stuff like that. So there we go. Just some soft tissue techniques around the foot. Obviously, if this patient had swelling, you could put them up, right? Let's get that foot elevated, right? This is one possible position. And then you can just squeeze in and around the ankle if you want to. That's an option. If the swelling is very local, like what you might see in an ankle sprain, if the swelling is very local, then you can just come and you can just spend time, right? Just gently pressing with your thumbs, working that swelling out of there. Okay. So I think that's enough time spent on soft tissue for the foot. Before I have Aiden come over and do some manipulations on the foot, we want to talk about distinguishing if your patient is missing dorsiflexion. Go ahead and flip over on your back. Go ahead and flip over on your back. If your patient is missing dorsiflexion, right? I've got my patient and oh man, like they can't they can't get the 10 to 15 degrees that they need, right? They should be here, but they're here. They're 0 degrees. So now the question you guys need to ask is this because the calf is tight, or is it because we have a restriction in the talocrural joint? The quick way to find out, scoot down just a little bit, come down just a little bit. So the quick way to find out is take the foot up to where the restriction is. Okay, now this could be the calf, it could be the talocrural joint. Okay, and I'm going to grab the foot, I'm going to place my thumbs just under the ankle joint on the talus itself, and I'm going to give a posterior glide, right, to the talus. If the restriction is from the talocrural joint, if the restriction is from the joint, I should not be able to glide the joint backwards, right? If the joint is tight, it should allow no more movement, and I really shouldn't be able to glide the talocrural joint much. If the talocrural joint does glide really well, there's tons of movement in that talocrural joint. The restriction is from the calf. So once again, dorsiflexion is limited. Is it the calf? Is it the joint? I'm going to take it to the limit and I'm going to glide posteriorly. If there's no glide, the joint is restricted and we should manipulate it. If there is a glide, it's more the calf and the soleus that's restricting us. So now you know where to spend your time. Do you need to spend your time on the calf and the soleus? Do you need to spend your time on the talocrural joint? I think just about any ankle or foot you see anyway should have a talocrural manipulation, but that's how you can determine where you need to spend the majority of your time, right? So I'm going to have Iden come now and do some manipulations on the ankle and feet. So let's take a look at a talocrural manipulation. Give me just a second here. Let me get this bigger. There we go. All right, there we go. All right. Say hi to Iden. What's up, guys? Say hi to Iden. So let's do the foot that's close to us, and then we can get that one out the way, and then we can do the other one. So for talocrural manip, just get a good hand on top of the foot. You can do this sitting or standing. Sitting or standing is fine. Lean back, thrust. Okay. Let's get this foot out the way. So you can just bend this little. Hard and fast. You literally have to lean your whole body weight to distract the foot. Like just lean back slowly with your whole body weight to distract the foot to the barrier. And then like a shotgun, you have to pull really hard and fast. And talocrural joint, you should at least feel a distraction of the talus. You should feel it distract and re-engage. Okay. Sometimes it'll pop, sometimes it won't. All right, but you should at least feel the distraction. And that is the same thing as what you should feel in the hip when we do our hip mobs and our hip distraction. You should feel that distraction. So every joint has a different feel when we're mobbing it and popping it. So that was really good. Let's do a midfoot. Let's do a midfoot minute. I'll just adjust this here. So we've got talus, navicular, and then the cuneiform, medial, intermediate, and lateral cuneiform. Today, we don't get time to go into how to feel each of these little joints and see who's moving and who's not moving, but midfoot manipulations are often required in all kinds of different patients, athletes and non-athletes alike. So Aiden's going to show a midfoot manipulation. Hug the foot, find your target, pisiform on the cuneiform you want to manipulate, hug the foot, squeeze, and I don't know if you heard it, but there was a little pop, so that was really good. You want me to do it? Sorry. Oh yeah, different angle. Yeah. Yeah. So take the hand, place it under the foot. I'm gonna come from this angle. Actually.
Probably can afford us.
Find your target. Good.
Small one.
Good. This is a short lecture, so we're not going to get too hard or heavy into it, but take the foot like you're giving it a handshake, right? Take the foot like you're giving it a handshake. Heel on the mat. My hand is on the mat. We're creating a fulcrum, okay, for this cuneiform right here. So I want to push on this while I'm distracting and lifting the forefoot. So make a contact, distract and lift the forefoot. We're basically like really shoving that cuneiform down. I'm going to put, this is surprisingly requires a lot of force. So I'm going to put my whole body weight above my hand, above my contact. See how my arm is straight? My body is above my arm. Okay. You can't really do it with a bent elbow. So straight elbow, body above your arm, compress, compress, compress. 1, 2, 3, and thrust. Okay, good job. You're hanging in there. All right, let's take a look at cuboid. So there are a couple of cuboid mobilizations and manipulations. And I tell you what, why don't we take 2 seconds? I'm not going to give you guys the full explanation, but we're going to take 2 seconds and I'm going to show you like the 2-second, how do you evaluate all of the joint mobility in the foot? We did talocrural joint, right? Bring it up, posterior glide. Is it moving or not moving? Thus talocrural, okay? Then we come from the talus onto the navicular. Navicular has a nice big round bump here, the navicular tuberosity. So I'm going to grab talus, grab navicular. I'm going to wiggle navicular up and down. Is that moving? Seems to be moving fine. Then I can grab navicular. Where's that bump? Okay, I'm going to stabilize navicular. Now I have my cuneiform right here. So I'm going to wiggle the cuneiform, right? Okay, see how that's moving or not moving? Come onto the cuneiform. And you can feel the joint lines and the connections, right? So you have to practice your palpation skills, but you can learn your way around the foot pretty good. Block cuneiform. I'm going to wiggle first metatarsal. I'm going to wiggle the second metatarsal. And I'm going to wiggle the third metatarsal. And usually you'll find first metatarsal has a good movement. Look at that. That's a lot of movement. Okay. Second metatarsal is usually a little bit stiffer. It's not uncommon that second metatarsal and the intermediate cuneiform are in dysfunction. Intermediate cuneiforms like the top of the arch, okay, the top of the arch, and sometimes that intermediate cuneiform gets jammed up, and you can actually feel that prominent intermediate cuneiform, all right? So first metatarsal, second metatarsal, third metatarsal, right? We're going to check the big toe. That big toe needs to come back at least 70 to 80 degrees. She's got plenty. She's almost at 90, okay? A lot of my big basketball players, they barely had like 10 or 15. Their big toes are shot and they're in their like 20s. It's crazy. Okay. So after we've done big toe, we're going to come to the other side of the foot now, okay? And I'm going to come at it from this angle. This is another place you can do first, second, third. For fourth and fifth metatarsals, since they attach to the cuboid, I'm going to stabilize the cuboid. I'm going to take fourth and fifth and I'm going to move them together. I'm going to move them up and down. They seem to be moving well. And I'm going to move them medially and laterally. Medially, fourth and fifth metatarsals should come to the midline of the foot. They should be able to make it to the midline of the foot. Okay, so that's how you test a joint mobility. Now that I've done fourth and fifth, let's come onto the cuboid with which they attach to. And cuboid actually moves in a diagonal direction. So it's like superior lateral and inferior medial. So I'm going to wiggle it in that plane, superior lateral, inferior medial. I'm going to wiggle that cuboid a couple of times. Hers is moving great. There's plenty of times, right, Aiden, where we find like stuck ones. And if it's stuck, if anything in this foot is stuck, it's taking away from the balance, the biomechanical balance. And little things like that can become a force riser. It becomes a place where there's abnormal forces. You can get pain. Why does a marathon runner get a stress fracture in the second metatarsal and nowhere else in their body? Sometimes it's because of these restrictions and stuff like that. And so if you're working on a foot, you should assess the foot at least from the joint perspective, right? You have to check the joints along with everything else. And then if you find something is restricted, you can pop it. If you don't know how to pop it yet, trust me, you can just sit there and mob it and wiggle it and mobilize it. Just get it moving, right? Manipulations are nice because they're quick and easy and fast. But if you can't do the manipulation yet, you haven't come to our courses yet, or you're still working on it, then mob it. Okay. And any of those mobs, they can become a quick thrust, a manipulation where we can actually thrust it and get it moving better. So I'm going to show you guys one technique for for cuboid, although there are many. So one of the ways that we can mobilize fourth and fifth on the cuboid is to just grab onto that cuboid, stabilize it really good, and then I'm going to take fourth and fifth metatarsals and I'm going to whip them kind of into like a downwards rotational like that. And this one, you don't have to really go to the barrier and thrust. You can just give a big old boom, boom, boom. Okay. And if it's stuck, you'll free it up, I promise. Okay. One of the things that we didn't check was subtalar joint. So if we see this heel here, let's see if I can get a better view of this. If you guys see the heel, the calcaneus, right? If your foot is in neutral, calcaneus should invert like 20 to 30 degrees, okay? And it should evert maybe like 15 degrees or so, okay? So I'll grab onto the heel and I want to see the inversion and the eversion, okay? And this is what that would look like from above. I'm going to grab the heel with both my hands, okay? I'm going to make sure the leg stays straight while I'm doing this, and I'm going to invert the heel. All right, there's 20, 30 degrees. In fact, she's got a lot. And then we're going to evert. And I want to see that it can evert to neutral and then another 8 to 15 degrees minimum. If they don't have at least 8 to 15 degrees of eversion, then guess what we're going to do is we can sit here and we can evert and evert and evert. That's a mob, that's an option. There's a whip, there's a calcaneal whip manipulation where I sit, turn the patient's leg out, their back of their thigh is in contact with my body, and I can use that in order to distract the foot. So I'm going to distract her foot out, and then we're going to flick the whole foot. And when we flick the foot, the momentum and inertia from the foot is going to pull, everything's going to pull on the calcaneus and pull it into eversion like that. So it's a whip. So 1, 2, 3, and whip it. Okay. And sometimes that'll give a nice pop for you. You can whip it, whip it, whip it. That's one technique. Another technique would just be, can you, maybe just like that, just something quick for the video. Another technique would be that you can place the foot on its side like this, can put something up under the malleoli, okay? You can come and do a push like this, stabilize the forefoot, and then you can mobilize the calcaneus into eversion, okay? You can mob it, you can even thrust it, okay? There's one more for calcaneal eversion, and you guys need to make sure they have it. You need to be checking for this. Go ahead and lay on your side facing that way. This is probably the best mechanical advantage you can give yourself. I'm going to bring this foot behind you. Thanks, Marcella. Okay, I think you have to see this one from the front. Okay. Calcaneal eversion. You need to check for it and we need to get it moving better. So, our forefoot will be on my leg. If your patient has been in chupples and walking around dusty streets all day, you can put a towel here or something like that. Okay. With my hand closest to her body, I'm gonna just put my fingers around her malleolus just so that I can hug the malleolus and support it so that that pokey bone is not pushing into a hard table. Okay. I've got her foot pretty stable here. So now that I've got her ankle stable, her forefoot stable, I can grab onto this calcaneus and with a straight arm and with my whole body behind my hand, I can drive that calcaneus into eversion. I feel like this is the best contact and control for mobilization, but also for take it to the end range and thrust manipulation. I had to demonstrate this technique for my final lab practical in my fellowship program, and I got a really nice cavitation on it. In fact, I was surprised. It's a funny story. All right. Earlier this week, I saw Aiden doing a fantastic technique for kind of for dorsiflexion, for walking, for calf mobility, for talocrural mobility. So we're going to actually take a look at that. I don't know if you want to set her up on the chair or on the table, and then I'm going to show that soft tissue technique. So this is a great mobilization with movement, and then I'm going to show you something that we can add to it as well. Just okay, sorry guys, we're getting set up. I hope no one's getting dizzy.
Put this right on your other way. And then put your bring this leg here. It's fine. Put your foot inside.
You guys have probably seen this if you've done any like mulligan courses or anything like that. And then,
Here you can just pulse it to it.
yep. And then Marcella can just lunge forward like that. This is mobilization with movement. You can bash out 30, 50 reps. Okay. That's a really great technique for talocrural. Since the knee is bent, it's going to be beneficial for soleus as well. That's good, Marcella. You can hop up. That was good. You can hop up. You want to see if you can hop out of this without losing any foot. There you go. And then I want you to come on. Well, I guess we can stay right here. I'm going to have you just stand kind of like in a lunge position like that. You don't have to use the stick, but it's there. Okay. So if this patient did have some soft tissue restrictions in the calf, one of the things that we could do is I can have her recreate that same kind of lunging movement. If you don't have a band like that, you can use one or two hands, right? You can come here and block the front of the ankle while they either with a straight leg, or you can bend this knee, or they can do it with a bent leg, right? Depending on if you're trying to hit more gastroc, soleus, or the joint itself, okay? The other thing we can do with the patient in this position is if they did have some soft tissue restrictions in the calf, you can take your knuckles and you can rake while they're stretching. You can rake along the calf. Some patients describe this as like knives. This can be a pretty uncomfortable technique, but effective too. So just something else, another option. But I really like the one that Ivan showed you guys, either with the strap or using your hands to block the front of the ankle joint. Doesn't matter if the restriction is in the joint or the calf, gastroc or soleus, that technique will be beneficial, and it's good because you're in weight bearing, right? We want to do as much with our patients in weight bearing functional positions. Okay. I think that's it for the ankle and foot area for now. I'll show you guys one more technique really quickly. This is getting a little bit heavier, a little bit deeper. But if your patient has experienced chronic ankle sprains, either one really bad one or a lot of little ones, these ligaments that attach onto the fibula and the foot, sometimes they pull so hard, fibula, and this is established. This is not me making this up. You can read about it in the literature. Sometimes the fibula actually gets jammed a little bit inferior and a little bit anterior, and that can mess with ankle dorsiflexion. It can make dorsiflexion limited. It can make dorsiflexion and eversion painful. And so there's times when ankle dorsiflexion is limited and there's some pain in and around the talofibular joint and stuff like that. And again, if you want to understand it better, you have to attend one of our lectures, but there's a mobilization for that. So let me show you what that looks like. We're going to bring the foot into dorsiflexion, eversion. Going to make like a lobster grip. This is called lobster grip, or it's almost like the little heart you guys see in, what's that, like Instagram or whatever. Dorsiflexion, eversion with my body, stabilizing her leg with one hand, and then pushing on the front of the fibula. I'll use a lobster grip with my thumb. Sometimes I'll get the whole heel pad of my hand on the front of that fibula, and then I can just drive through kind of this softer part of the hand. Now, putting pretty significant mobilization force on that. That's like grade 4. Okay. Scooch on up, Marcella. Just scooch on up this way. Okay, knee flexion and extension, mobs and manips. I can stabilize distal femur. I can grab around the Achilles, kind of by the ankle. We can do mobs here, right? I can really lean in and stabilize and lift. See those mobs for extension? Since we're in end range, it's helpful if you guys will give a little bit of external rotation in those last 10 to 15 degrees of knee extension. That's correct biomechanics, okay? A screw home mechanism. Stabilize the femur, pull the tibia, and externally rotate it. That's a good one and you can manipulate that, right? I will sometimes if there's like a block, sometimes we'll give that a manip. Scooch, let's see. Oh, there's one like this. So sometimes if you have like an end range flexion restriction, so they get here and it feels like a block, like, oh, it feels like something needs to pop, or it's like painful or uncomfortable, you can place a hand or even a forearm here, give a little bit of pressure, and then at the end range, give a little thrust. And this hand here creates a fulcrum, which will help the tibia distract off of the femur. We can do that in prone as well. Lay on your stomach. I use this one quite a bit for like end range flexion. So I'll put my forearm here, and then as you bring the heel to the buttocks, my forearm, like I said, is creating this. Let's see, there's the femur, there's the tibia. My forearm is creating this wedge so that the more I flex, the more the tibia is distracting from the femur. So it will give a better capsular stretch. It'll stretch out the ligaments a little bit. If the meniscus is caught It will give a nice distraction force to the internal knee joint so the meniscus can pop or move or do whatever it needs to do while the joint surfaces are being distracted. That's a good way to do it. Okay. Aiden, will you come and block for me? There's a knee manipulation. If you have an assistant come and block the distal femur. Or you can belt it down, but having a person block it is probably better. I can distract the knee. I can distract and scoop it into extension if they're missing extension. So there's a distract and scoop it into extension. And I can also just distract and give a thrust there. That was nice, actually. That was a nice one. Okay. Flip over onto your back. Flip over onto your back. I'm not going to actually do it, but of course you guys can come and do like nice, right, front of the thigh work, right? There's your petrissage. Then you can go with fists, right, for that little deeper layer. And then of course you can go with your thumbs, just along quads, anywhere that you need to do that. It works really well. I would say lateral thigh, that can get kind of tender, kind of nervy. We get a lot of referral from the hip, the pelvis, and the back out here. It's a lot of nerves. And so sometimes rolling that's a good idea. Just have to adjust whatever pressure you want to. And keep in mind that soft tissue is like the fourth or fifth thing that we would be doing, right? I think addressing the joints and nerves usually comes first. So speaking of the nerves, you guys have all had patients with lateral thigh pain, hamstring pain, calf pain, pain in the foot, pain in the bottom of the foot, like sciatica, nervy stuff. So I want to show you guys a great technique to open up the space in the back where the nerves come out and then do some nerve flossing. So let's start from the beginning. Let's pretend like Marcella has sciatica, right? This is literally what I would do in my first treatment with her. We manipulate the thoracic spine. When you manipulate lower thoracic spine, it has a neuromodulatory effect on the lower extremities. When you manipulate the mid and upper thoracic spine, it has a neuromodulatory effect through the sympathetic nerve root ganglion to the upper extremities. So if you have a patient that has pain anywhere from the lumbar spine down, you should do a thoracic manip. If they have pain from the thoracic spine up, you should do a thoracic manip, as long as it's not contraindicated by a fracture or a cancer or osteoporosis or something like that. So here's our thoracic manip. You guys saw it last time. Opposite arm on top, other arm underneath. The arms are over each other. They're not crossed, okay? All right, we're not going to mummify her. So then either a flat hand or a fist on her thoracic spine. I'm going to stack my chest, my hand, her elbows, her body. We're going to stack everything vertically above my hand and then squeeze 1, 2, 3. And minute. Good job. You did good. Okay. So that's for neuromodulatory effect to help us with what we're going to do in a little bit. Okay. And then the next thing we would do is we'd have to test if she was appropriate for a lumbar spine manipulation or not, because either we're going to manipulate lumbar spine, or maybe we're going to do some decompression, or maybe we're going to do like a McKenzie approach. Depends on which category she would fit into. But let's say she's a candidate for a lumbar manip. Lay on your side facing me. If she's having symptoms in an L4 dermatome, like the lateral leg, then I want to target L4. If it's bottom of the foot, then I want to go after L5S1, right? So depending on where your patient's pain is, you should specifically target that segment. You don't just pop the whole back and pray to God it works, right? So I'm going to have her, I'm going to twist her up. We're going to go with L4. So I'm going to find her sacrum. I'm going to find her L5, her L4. We teach how to find that easily and accurately in our courses. There's several different ways you can do it, but we're at L4, so I want to pop L4, L5. So I'm going to twist her up, grab onto your hands, and I'm going to come under your arm here. Okay. And I'm going to block L4 with my thumb and with my arm. So I've got her whole body, this whole part of her body is tight and stabilized by my hand, my thumb, and my body. And then I'm gonna roll her towards me so that I can get my chest on top of her pelvis. And then at this point, I just have to drop my body into her pelvis. 1, 2, 3, 4. Okay, manipulate that. Lay on your back. The next thing I would do would be a hip manipulation. You guys saw that last time, right? Grab the foot. We're gonna do some oscillations first, just so I can make sure. Let's see how that feels for my patient. I'm looking at her face, seems to be fine. This is not hurting her. I'm also getting a good gauge for the mobility of the hip. I can feel it distracting a little bit. This feels good. You can do 8 or 10 of those or more. After a couple of reps and she's relaxed and trusting me, I can lean back and give a good thrust. Okay. So we've done thoracic, lumbar, and hip. Are we going to do the SI joint? Yeah, if it's needed. Flip over onto your tummy. If a patient goes like this and they point at their SI joint, 100% that SI joint needs to pop, okay? 100% you need to mobilize that thing. You can also check if I come on the back of her and if I stabilize her sacrum and give her hip bone a flick, I'm going to move it back and forth. I can feel the mobility of the SI joint. The SI joint, just like any joint in the body, should have about 1/8 of an inch. I think that's like 1/2 of a centimeter of play. There should be about 1/8 of an inch or 1/2 a centimeter of movement. So if I just wiggle this SI joint, blocking the sacrum, wiggle SI joint, right? There should be some movement there, some play there. I'll compare sides, right? We'll compare left and right. So if a patient goes like this, you need to pop it. If you find stiffness on that side, you need to pop it. If you palpate, right, here's the PSIS. If you find PSIS, then you come a little bit up and a little bit in to sacral base, and all throughout this joint, and even extending from the sacrum to the spinous process and from the sacrum to the ischial tuberosities, there's a huge ligamentous network. And if you find tenderness anywhere in those ligamentous network, then the sacrum and the pelvis are not aligned properly and we'll need to align it. So I can palpate, there's PSIS, okay? I'm gonna come up and in, I'm gonna palpate that. I can palpate for tenderness. I can also palpate and see if the sacrum is more prominent on one side or if it's deeper on one side. So palpate at sacral base. Put my fingers at sacral base, bring my thumbs down, and I'm going to palpate the inferior lateral angle of the sacrum. Palpating for tenderness, palpating for asymmetry. She's definitely more prominent on the right. Is there any pain or tenderness there? Does it feel okay or does it feel different? Feels fine? Okay. And so yeah. So if a patient is having any kind of leg pain or sciatic pain on this side, this SI joint, more often than not, is going to get manipulated for mechanical reasons, for neurological reasons, for other reasons. So I'm going to have Aiden go ahead and come and block for me. Let's see, we were pretending like it was the right leg. So I'm going to have Aiden come and block for me. And then we're going to give this a long axis distraction. All right, Marcelo, your job's just to relax. Just gonna give this leg a little pull, okay? I'll be nice. 1, 2, 3, and the 4. Okay. All right, so we have just addressed biomechanically the joints. So now that I've done that, right, I'd probably follow it up. We could do some heat and some stretches, cobra, child's pose, pigeon, right? Some of that kind of stuff. Those are great ideas. I would want to do something for the nerve, right? Anytime a patient has nerve, we have to do something for that nerve. Open up the foramen, stretch the nerve. This is how we're going to do it. Sit up facing me. And then we're going to show you guys how to do the exact same thing in the neck. So sit up. I would say 90% of the time, the patient's going to love this and it's going to feel good. If you set a patient up on it and they can't tolerate it, play with it a little bit, but if they still can't tolerate it, then it's not for them, okay? So not every exercise or stretch works 100% of the time. So don't force a patient into it if it's making things worse. So you're going to lay over this pillow, put your head on this one. So we've taken her spine. It's now been bent up. The neural foramen on this side are more open. The joints are distracted. And the discs on this side are also unloaded. So this is going after joints, nerves, discs, even the muscles here being placed on a light stretch. This is an amazing stretch, so useful. Okay. Why should I put a pillow between the knees? Why should I put a pillow between the knees? You see how, especially in women that have hips, but just anybody, right? Why should I have a pillow between the knees? When her leg is here, her hip is in neutral. When her knee is down here, her leg is in internal rotation and adduction. And guess what happens to piriformis? Piriformis gets pulled tight. When it gets pulled tight, it's going to compress. And you guys know that sciatic nerve is very close with piriformis. Sciatic nerve can exit over piriformis. Sciatic nerve can exit through piriformis. And sometimes you get some of sciatic nerve is like this and some of it's like this. Like there's variations. So for a million reasons, right? Piriformis, the fact that when your knee comes down, it pulls your pelvis forward and puts a rotation in your spine. So for a million reasons, pillow between the knees, okay? We're trying to help here, not make things worse. So pillow between the knees. Neural foramen are opened. Sciatic nerve is getting plenty of room to breathe. And now what we can do is we're going to just do sciatic nerve glides in this position. So how do we do that? We just extend the knee, pull the toes to the nose, and I instruct my patient that you might feel a stretch anywhere from the foot up into the back. I don't care if you just feel it here. I don't care if you just feel it here. I want you to go until you feel a 1 out of 10 stretch and then come off of it. The research says that subsensory sliders are better. In other words, if we did this in a way that she felt nothing, that's better. But what's the problem if she feels nothing? If she doesn't feel anything, then she doesn't know if she's doing it correctly or not. I don't know if she's doing it correctly or not. And if she's doing this at home, nobody knows. So I like for patients to feel it a tiny bit, like a 1 out of 10, and then come off it. Dosage, I'll usually have patients I'll tell them do 20 of these and then take a break and then do 20 more. Sometimes we'll do 1 or 2 or 3 sets like that, right? If you wanted to come in here while the patient's doing this and like do some tissue work, like work on the nerve a little bit, like work it out, you can, but it's not necessary. Just let the patient do their nerve glides. Give me 2 more just like that, Marcella. Just let the patient do their nerve glides. It's effortless. The weight of the thigh is relaxing on top of the other leg. This is virtually effortless, okay? You have to make sure the patient's not doing more than a 1 out of 10. Most of your patients will do this too hard, and if they do it too hard, too fast, too long, they're going to have a temporary increase in their symptoms, and we don't want that. That is not the goal. Cool? All right, cool. How can we do the same thing in the neck? And even before we do the neck, you guys get a bonus. We'll do saphenous nerve. We have a saphenous nerve lecture on YouTube. You can get it, or you can catch us in person sometime. But basically, there's a nerve that comes and feeds the inner part of the knee, the front part of the knee, called saphenous nerve. Sometimes it gives us pain. If we establish that saphenous nerve is involved, we need to pop the lumbar spine, L2 through L4, probably the hip, probably the SI. And now let's say that I'm doing my nerve glides for saphenous nerve. for any knee pain, especially if they've had a surgery or if they can't tolerate pressure to the knee, like they can't tolerate their knees touching, we can come in and do a saphenous nerve glide. So I'm going to bring the leg up. I'm going to bring the hip into extension. And just imagine there's a rubber band, femoral nerve, turns into saphenous nerve, runs like this. So I'm going to bring the hip into extension, abduction, external rotation. Now I'm stretching that rubber band a little bit. And then I'm going to grab the foot into dorsiflexion and eversion. And I'm going to pull back until the patient tells me they feel either some knee pain or some stretching on the inside of the thigh or the knee. We're going to do 20 reps. This one needs a little bit more assistance. There's a self version and standing, but first time or two, usually I'm the one doing it. So we're going to just stretch to a 1 out of 10 and come off it. Stretch to a 1 out of 10 and come off it. Saphenous nerve. Check out our video on that one. Very interesting. You'll see the technique I just demonstrated and you'll understand it better. Surprisingly common cause of chronic knee pain that's not getting better. All right, you can go ahead and sit up. On the topic of nerve glides, let's look at what we can do for a neck. Let's say you've got a patient with cervical radiculopathy. Come lay on the back. Marcel is a little new to us, and she's a little afraid of having her neck popped, so we're not going to do that on her, and that's totally okay. You guys have to respect patients' preference, right? We've all seen movies or heard stories, so there's people that don't want it. It's fine. We're not going to force it. Always educate your patients and get consent, right? We don't be that person. I've heard stories of patients that go visit chiropractors and they come and see me. They're like, I will never have my neck popped. Don't pop my neck. And I'm like, okay, what happened? Either they saw the movie or they heard a story or they saw the chiropractor and the chiropractor didn't tell them and they just like whipped their neck, just boom, like big, strong, powerful, violent, the opposite of what we do, which is gentle, precise, and controlled. And now the patient has PTSD and they don't ever want to have their neck touched again, right? So that happens. So anyways, make sure you're not that guy. So we're not going to pop anything in here. But let's say that Marcella had cervical radiculopathy, right? Pick a distribution, right? It could be C5, which is like the kind of the shoulder. It could be C6, which is going to be like the forearm and the back of the hand here, right? Kind of that tennis elbow distribution. C7 or C8, that's kind of the lateral fingers, the outer arm, that golfer elbow area. So pick your distribution, right? And I'll show each of the nerve glides. Cervical radiculopathy, we would manipulate thoracic spine, manipulate CT junction. I would check for rib dysfunctions because the first 4 ribs could be contributing or causing her pain. So we'll check the first 4 ribs. If there's dysfunction there, pop it if necessary. I would feel her neck. We'd probably pop the segment that's involved. So if it was C5, let's go with C5. No, let's go with median nerve. Let's go with median nerve, which is like C5, 6, and a couple of others, right? So I would probably pop her lower neck. If her lower neck's not happy, her upper neck has probably not been happy. Pop the lower neck, pop the upper neck. You guys remember the suboccipital release? Just relax your head. I'll probably come in here and do a little bit of that. Get the patient to relax. Get the muscle tension down, right? Do that a couple of times. And then I'm definitely, if there's a neck problem, the scalenes are always tight. And if the scalenes are tight, that means first or second rib has been pulled up. Okay, remember we talked about that triangle. Here's the scalenes, here's first rib, and how the brachial plexus runs through there. So we would need to stretch the scalenes so that first and second rib can sit where they should, and first and second rib are not contributing. Scalenes and first and second rib are no longer contributing to this mess because they oftentimes do. So this is where we do the MET. I'm going to block first rib and second rib. I'm going to turn Marcella's head away until she feels a little stretch. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. turn away, 1, 2, and we would just repeat this until she can turn 80 to 90 degrees. It usually doesn't take more than 8 or 10 reps, right? So stretch out those scalenes. Okay, now that I've popped thoracic, CT, ribs, neck, stretched out the scalenes, so I've removed anything that should be causing her pain, really. I've removed so many things that can be causing or contributing to her pain. Now we're going to go after a little bit more symptom relief. We're going to do some nerve glides. You could simply do nerve glides, but I love doing nerve glides with the foramen more opened. Those spaces where the nerves come out, let's open those up. So we can use this. It's like a 15 or 20 US dollar cervical decompression device. Very cost effective. Lift your head up for a second. If you're using it on a lot of patients and you're worried about like it being sanitary, you could keep a pillowcase or a towel or something in between the patient and this thing. I'm going to pump this up until Marcella feels about a 3 out of 10 stretch in her neck. Until she feels some stretch or until she feels some relief. Okay. So she's having pain right now. All right, Marcella, I'm going to pump this up till you feel some stretching in your neck. Maybe you feel a little bit less pain. Just tell me when you start to feel something. There. What does the research say about traction, whether you do it with your hands or this device or the machine, right? We know that intermittent traction is better than sustained traction. So instead of me putting her on this for 15 minutes or 20 minutes, we're going to do 3 minutes, do some nerve glides. I'm going to let it down, pump it back up, and then again, right? So we've got it pumped up. The spaces in her neck where those nerves come out are more opened. And now is a great time for us to come and do some nerve glides, right? Median nerve glide is the pizza. So she's here, 90 degrees at the body, 90 degrees at the elbow, 90 degrees at the hand. She's holding her pizza. And then we're going to just put the pizza down on the table, right? That's median nerve, okay? Same thing. I want her to go till she feels like a 1 out of 10 stretch and then come off it. Should be virtually effortless. All right, there's median nerve glide. If she was having ulnar nerve symptoms, then we're going to have tea with the queen, right? So put your fingers like that. So there's the teacup. There's the posh fingers up in the air. And then we're going to bring that teacup kind of to the ear, right? There's ulnar nerve. Ulnar nerve glides go to you feel like a 1 out of 10 stretch. Do 20 reps, right? Radial nerve. Radial nerve is the sissy punch. So thumb in hand, flex the wrist. The arm is about 30 degrees out from the body. And we're going to do a little sissy punch back here. It's also like a waiter's tip position, right? So it's like this. Grab the thumb, arms 30 degrees away from the body, and punch down to feel some stretching or some pulling in the tennis elbow area. Okay. And I'll show the patient how to do this for a couple of repetitions, and then I will let them do it. Right? Show them how to do it properly. Watch them do it a couple of times. Okay. So we can do nerve glides with cervical decompression, with lumbar decompression, where we lay over the pillow. Amazing techniques clinically. I highly recommend them. 10 out of 10. Take that. Okay. Go ahead and lay on your stomach. Don't remember if I showed this one. I'm going to show lumbar rocking. I think we did do that one last time. Did? Okay. Hands on paraspinals. You can, the layers of palpation, shirt, skin, muscle, transverse processes. So I'm going to come to the muscle layer and I'm just going to rock her paraspinals back and forth. As I'm going up and down the paraspinals, I'm looking to see if there's any restrictions or tightness, right? Any restrictions or tightness. If I do find tightness in the paraspinal, then I'm just going to sit and rock on that spot, right? I'm going to rock on that spot, or I can rock on that spot, okay, until it relaxes and loosens up. I can also palpate the deeper layer, compress the muscles down to the spine, and I can check the spine mobility. How well does the spine move this way, that way, this way, that way? And if I find, oh, this is not moving that good, cool, I can mob it, or we can lay her on her side and we can manipulate it, right? I think what's left is like shoulder, elbow, hand. So yeah, we've got 10 minutes. Let's do shoulder, elbow, hand. Let's go. Marcel, if you want to lay on your back. For the sake of time, I'm not going to do the whole thing, but for soft tissue, for a shoulder surgery, frozen shoulder, right? We can do our big strokes, then we can do our fists, then we can take our thumbs, and then we can just rake our thumbs 1 centimeter at a time all around the front and side of the shoulder, right? We can come in, we can pinch that subscap and the teres muscles, right? We can keep pressure on the subscap and teres muscles and get them to release, especially in like frozen shoulders, right? Get those to release so we can improve the shoulder mobility, okay? We can do the same for pecs. We can pinch, come into the axilla, pinch pec major, pec minor, pinch those guys. Yeah, she doesn't like that. While we do different shoulder movements, see if we can get that to let go. Dry needling is amazing for these areas. We're going to have a dry needling lecture later. Dry needling is amazing for muscles that are tense and tight and don't want to let go. My first shoulder mob on any patient is usually a distraction mobilization, even if they're post-operative, because it just feels good. This is the sequence. Grab it, and then I'm just going to tuck her hand. She can hold onto my bicep, or I can just squeeze her hand with my body, right? Now I've got my hands available to really get up in there and hug onto that humeral head, okay? And just relax your arm. I can do a distraction mobilization, which is pulling the shoulder a little bit kind of up and out. Okay, so distraction, I can just distract and hold it. If the patient is a very acute post-operative patient, I'm just going to distract it and hold it. That's going to feel good. It's going to let the patient start to relax. Distract and hold. I can also do some oscillations. And the moment, as soon as I do this, there's other methods, of course, but as soon as you do this, you can get a really good idea of how well is the shoulder moving. If they have frozen shoulder, there's no play. There's no play. The shoulder and the shoulder blade are moving together. But I can feel that she's got good play between her shoulder and shoulder blade, right? And if I feel that, I'm like, okay, well, that's moving well. We don't need to do this. We're going to move on, right? So you can do it for pain relief. You can do it for to have the patient relax and stuff like that. That's a lateral mobilization. We can do a inferior glide, right? Mobilization. We can do inferior glide with external and internal rotation, right? And you can turn this into a muscle energy technique if you incorporate holds and stuff like that. That's in our MET lecture. Of course, posterior glides, right? Inferior and posterior are usually the most needed glides in a shoulder. I like to try to get a big, soft palm on top of the head of the shoulder. And then with this hand and my body, I'm actually, watch that, see? So I do have a good contact here, but it's not all this hand. My body and my other hand are helping me with that posterior mob, okay? There's another posterior mob, like so. Impingement patients may not tolerate this one, but you're gonna just stack over her elbow Sink in, 2, 3, 4, 5, come out of it, sink in, 2, 3, 4, 5, come out of it, sink in, come out of it. There's a distraction manipulation, kind of like how we wedged our hand in the back of the knee. I'm gonna wedge my hand in her axilla, bring her arm across her body. And I can start to push with this hand, right? Distract, distract. And you can manipulate or you can just distract, okay? There's a manipulation where we go into a lateral manip, okay? Her elbows on my shoulder. No, just relax. Her elbows on my shoulder. My hands are scooped around her humeral head. And the pull is purely lateral. Boom, boom, boom. Okay. I use that sometimes in frozen shoulder, freezing stage, frozen stage, thawing stage. Thawing stage, it's loosening and they don't have much pain. I usually use this technique in thawing stage. In thawing stage, I use aggressive manual therapy to improve the mobility of the shoulder. You wouldn't really use it in the freezing or frozen stage necessarily. Just you can decide based on your patient. That's a lateral manip. There's also an inferior manip. So we're just going to change the position here. It's the same technique. Elbow in my shoulder. My hands are scooping around her humeral head. We can mob it a little bit and we can also give it a quick boom. You guys can see. Okay. I think that's pretty good for shoulder. Do you mind if Iden pops your elbow and wrist? Okay. Let's talk about the elbow for a sec. Probably the most common elbow diagnosis you guys will see is tennis elbow. All right. So for tennis elbow, the research actually says we should pop C5, C6. We should pop the radiohumeral joint. We should pop the wrist. After that, the evidence would say tendon loading, right? Isometrics, concentrics, eccentrics, plyometrics, tendon loading. And then the other things would be complementary, whatever else you want to throw at it, right? If you want to throw some soft tissue at it, if you want to do some needling, you can. I think needling evidence is decent. It's not amazing, but it's decent, I think. Usually there is some neural tension, right? So some nerve glides is a good idea, right? Just decompress the neck, do some radial nerve glides. You'll also be stretching those muscles and tendons at the same time. So that's not a bad way to go. But yeah, if you want to go ahead and hop on up, you can go ahead and stand up. And then, yeah. Good thrust. Good thrust. Do mine too. Please. Do mine too. I'm going to give you guys a different view. So thumb on radial head, extend, and nice. Okay, and then wrist. Nice, great. Let me have your hand. Let me have your elbow in hand. All right. Yeah, that one popped yesterday. All right. So gonna hold, I'm standing next to the patient, holding the wrist here. I'm gonna contact the radiohumeral joint, the radius, specifically the head of the radius. You can palpate that. You can use your thumb there as a contact. You can use these two fingers as a contact. Either way, you need a good contact there. And then bring the elbow into extension, bring the wrist into flexion. We're also going to, let's see, I guess that's pronation there. Mini thrusts at the barrier, one, and then hammer it, hit it hard, okay? For the wrist manip, we're gonna put ideally one thumb on, you guys remember your acronym, scaphoid, one on lunate. So one on scaphoid, one on lunate. Okay. Right at the wrist joint line. And then I'm going to bring his elbow and arm into a little bit of extension. I'm going to create a distraction force. So I'm going to distract the wrist. And with that distraction force, I'm going to just thrust scaphoid and lunate down, kind of in a palmar and distal direction. Okay. And what you see in a lot of tennis elbow patients, if this is my affected side, you'll say, do this. And that's what it'll look like. Affected side, usually there's a wrist extension lag. And once you manipulate the elbow and manipulate the wrist, that will improve. Of course, you can follow that up with some, stretches, some strengthening and different things like that. So, it is, hey ladies, it's 9:30 and I think we've covered the techniques that we're going to cover for today. Just so you guys know, next week, Sunday morning, our time, Drumi will get you guys the details and stuff like that. We are having a lecture on headaches and migraines. This lecture is actually going to be a paid lecture. I think it's just under 500 rupees, so it's not that much, but it's going to be a paid lecture on headaches and migraines, where we're going to show some theory. We're going to show give some explanation as to why these patients are having symptoms. We're going to show some manual therapy for the upper quarter. We're going to show some dry needling, the dry needling routine that works really good for headaches and migraines, and just about kind of overall management. And you never know. We might throw in some other stuff. We might talk briefly about um, whiplash and concussion, because that comes with a lot of headache and migraine patients. But yeah, thank you guys so much for attending and joining in. Hope you guys will have a good weekend. And feel free to reach out about the course for next weekend is paid. After that, we have more free lectures. So, stay in the loop and stuff like that. And definitely, if you haven't already signed up to join us in India for that week in December, make sure you guys come. It's going to be worth it, okay? So thanks. Have a good weekend. Bye. Thanks, Drumi, for hosting us.